themes are really at the top of mind within the Pakistani healthcare system that the country is looking to solve?
Pakistan's issue is number one, the doctor patient mismatch. Number two, doctors not available in primary care, more doctors available in tertiary care, which creates undue load on the tertiary care hospitals. And third, all of the system that I've told you, the public health ecosystem, because of lack of facilities, people actually end up going to private hospitals rather than public hospitals for their healthcare needs. 70 to 80% people spend out of pocket despite being a public healthcare system. That creates a huge problem because people then have to pay out of pocket as well. And insurance is not available in Pakistan on a mass level, but majorly health insurance has always been a corporate structure in the country. So out of pocket expenditure also becomes another challenge where we live.
Welcome to the Next Scale Community Podcast, and I am very excited to be joined by Dr. Saeed Khurram today. Dr. Saeed Khurram is the co-founder and CEO of Sehat Kahani. Did I get that right in pronunciation?
Yeah, you did. You did.
So Dr. Sara is coming today from Pakistan, and she has built what I believe is the largest telehealth business in Pakistan with over 7,500 providers on the platform. Is that correct, that you're the largest telehealth platform in the country?
I'll say one of the largest.
One of the largest. Okay, fair enough. But this is my first interview with an international CEO. And so we're very excited, just like we do here with US-based healthcare CEOs featuring innovative leaders and companies doing interesting things to advance healthcare. This is the first time where we're taking the show on the road and featuring a global CEO doing interesting things in another country, in this case, Pakistan. So welcome and very excited for the conversation.
Thank you. I'm very excited as well.
So maybe for those that are less familiar with the Pakistani healthcare system, before we jump into Sehat Kahani specifically, which we'll spend the bulk of our time on, can you just give us a quick overview of some of the key themes in the Pakistani healthcare system that as a country you're focused on? So here in the US, cost of care is a key focus. And, there are a number of other areas, but what themes are really at the top of mind within the Pakistani healthcare system that the country is looking to solve?
Sure. I think, Jason, the first thing to consider is Pakistan is a big country. We're the fifth largest population in the world. So there are around 240 million people in the country. Now, the first theme that I'll touch on is the doctor patient mismatch that we have. So we have 240,000 doctors. That means there should be one doctor for 1,000 patients. But majority of the medical workforce is made up of women doctors. And because of social cultural barriers, a lot of women doctors in Pakistan don't practice. They become what we call doctor brides, which is one of the reasons why we created Sehat Kahani. But more from a theme perspective, when a lot of doctors, female doctors, don't work after marriage, it creates a gap in the health ecosystem. Now, Pakistan is also a country from which a lot of young people move out for better work opportunities. To one of those countries is the USA. So every year, 25,000 doctors move out and do their residencies abroad and they do their medical programs. So in actuality, we have less than half a doctor for 1,000 patients. Now, almost 75% of these doctors want to work in the urban areas, but rural areas in Pakistan make 60%, again, a majority of the country. So where 60% of our country lives, only 15% of the doctors want to practice. Now, the healthcare ecosystem in Pakistan is ideally a public health ecosystem. So if you're sick, you go to a primary healthcare center. From there, you go to a secondary healthcare center. And then if your issue cannot be treated, you go to a tertiary care center. Now, because we have less number of doctors available, those primary healthcare facilities either don't have a doctor at all or don't have a doctor most of the time. So what do people in low-income areas or rural areas or villages or communities do? They end up going to quacks, midwives, faith healers, people who are not supposed to provide healthcare to get that primary healthcare. And that is where the medical malpractice, the medical negligence happen. That is where they get mistreated or not treated at all. Now, eventually, when they land to a tertiary care hospital where doctors are available, the issues that could have been held at a primary healthcare level worsen to a tertiary care problem. So, for example, if they had high blood pressure, it becomes heart failure. If they had primary kidney issues, they turn to end stage kidney diseases. If they had insulin resistance, it goes to diabetes. If they had maternal complications, it turns to maternal mortality. If they had infections, it becomes sepsis. Pakistan's issue is number one, the doctor patient mismatch. Number two, doctors not available in primary care, more doctors available in tertiary care, which creates undue load on the tertiary care hospitals. And third, all of the system that I've told you, the public health ecosystem, because of lack of facilities, people actually end up going to private hospitals rather than public hospitals for their healthcare needs. So in Pakistan, 70 to 80% people spend out of pocket despite being a public healthcare system. That creates a huge problem because people then have to pay out of pocket as well. And insurance is not available in Pakistan on a mass level. It is only available at a corporate level. There were some programs in the past, there still are programs in the past. They're trying to create public health insurance also. But majorly, health insurance has always been a corporate structure in the country. So, out of pocket expenditure also becomes another challenge where we live.
When you say tertiary, is that referring to hospitals or specialty care, or it can be both?
So I'm referring to big hospitals, which provide specialist care as well as hospitalization, which is surgeries, operations, longer procedures, and longer term care.
You mentioned the supply shortage on the provider side and primary care. Is that also something that you see on the specialty care side?
Absolutely. So it trickles down, right? You have lesser number of doctors, lesser number will become the primary physicians, even a smaller percentage will become specialists. So in Pakistan, a lot of people suffer because if you go outside the main cities, so there are 5, 6 main cities in the country, but if you go outside the main city, then you do not find specialists. And then people have to travel longer distances to come to a tertiary care facility in a big city where I am, like Karachi, and show to that specialist. Now, what happens is sometimes when I go to that specialist, I see people sitting in the waiting rooms with their suitcases or with their cabins where they've come from a smaller city to show a doctor and they wait the entire day, they spend the night, and then they go back. Now, from a travel perspective, from an opportunity perspective, from a time perspective, from a financial perspective, this is just increased burden of care that falls on the patient. So yeah, those are multiple challenges within this small challenge in itself.
So you mentioned the rural urban divide. You mentioned a provider shortage. You mentioned lack of primary or shortage of primary care leading to an overutilization of tertiary care hospitals. And you mentioned needing to access the private hospitals over the public side, sort of as the key themes that you're referring to, and also a leakage of talent for various reasons, whether it's providers that choose not to go into the profession or providers that leave the country. So I think that sort of helps set the stage for the dynamics in Pakistan that the country is focused on. In terms of funding healthcare, it sounds like it's the first level of funding would be public care, and the second level would be private insurance through corporations for those that have that opportunity. In terms of providers, who's employing these providers? Are they also employed by the government, or are they private practice? What's that dynamic in Pakistan?
So the doctors are primarily employed by the hospitals.
Okay.
So in the private practice, the primary provider, the primary payer is the hospital. Yes, there are opportunities and multiple opportunities in the government setup as well. But then again, there are very limited opportunities in the government setup. There are many instances where doctors, even if they are told to go to a primary care facility, they end up not showing every day. And it's difficult for a doctor to do that because if you've studied a long time to get a degree and you have spent a lot of money in getting that degree, when you go to a primary care facility in a village where you have no facility for yourself, it becomes difficult for someone to live in that village, bring up children in that village. They would definitely choose either an opportunity in the main city, or if they can move out of Pakistan to other geographies that do provide better pay and better quality of living as well. So those are doctor challenges which are pretty valid. So both can employ doctors in the government and private setup, but financially also, doctors do not end up making a lot of money till they reach a consultant age, which is very far along their medical journey. Even financially, they aren't reciprocated as the same way as maybe the doctors in the US would or Canada would, which also gives them this feeling that, okay, why don't we just go to the other country and make more money? For example, right now, a lot of doctors are moving to the GCC region, which is again a good opportunity to make money. So that is one of the factors that we see for doctors moving outside as well.
We're going to get into Sehat Kahani just in a second. Are there any, besides leveraging telehealth for creating sort of broader access and broader supply on the provider side, are there any other strategies that Pakistan has adopted? So, for example, in the U.S., we have a concept of a mid-level, a physician assistant, or a a nurse practitioner, and so we've created capacity through additional functions besides licensed physicians. Is there a similar concept in Pakistan that you've leveraged nurses, nurse practitioners, physician assistants?
I think that's a great question. I think Pakistan was one of the very few countries that in the 1970s created a model which was called the Lady Healthcare Worker Model, the LHW model. And around 5 to 6,000 of lady healthcare workers were created at that time. And their primary role was to address this very shortage of doctors in low income areas with respect to health education, counseling, family planning, and birthing also. And later on, there were a lot of cadres of healthcare workers created. So we have lady health visitors, we have midwives, we have community midwives. Because when we think about primary healthcare issues, the bigger primary healthcare issues that have always daunted Pakistan until recently were maternal and child healthcare issues. Because we had high maternal mortality rate, high infant mortality rate, one of the worst neonatal mortality rates. Now, non communicable diseases such as diabetes and hypertension have also showed up. But for a longer time, communicable diseases and MNCH was the focus at primary care. So we did create these cadres of workers. Now, over time, they have somehow maybe not driven to their full potential. So we still have these different cadre of workers working in different areas, but right now they're utilized maybe in polio campaigns, or they can provide birthing and family planning, but they're not trained to accustom themselves to the knowledge that people seek now. So they're not very digitally enabled. They don't know how to counsel patient right now for family planning, because the patient of now and the patient of 1970s is very different. You need new tools to be able to counsel them. And what we've seen, and that I think is a big part of what Sehat Kahani does, is because these lady health visitors or community midwives are sometimes the only source of healthcare in the community, people end up going to these workers for everything. So over time, they start becoming quacks and they call themselves doctors.
Mhm.
And they start treating the patient for everything, which again increases malpractice, malnegligence, overusage of antibiotics, misdiagnosis. So there are a lot of cons that are created. And I think that model of creating allies to doctors in communities isn't used to its full potential. Not there's limited accountability for it, and that's why we don't see it growing to a potential where it can actually be used in conjunction with doctors to aid to primary health.
So tell us about Sehat Kahani. I would love to hear a little bit about the history of the company, what led you to found it, and then where you are today in terms of footprint, number of providers, number of patients, and where your focus is.
Yeah, so I think I mentioned that Pakistan suffers from a Dr. Bright phenomena, and I touched upon that already. So my story started that I belong to a middle class family. I was the youngest daughter after two sons, and my father told me at
That's okay.
so my story started when I was 5 years of age, and my father told me that I have to become a doctor. And for the next 14, 15 years of my life, I studied to become a doctor. I was never given a profession to choose. I thought this was the only profession I would go into when I grew up. But when I went to do my medical college, 90% of my class was also women. And I learned that they had also been fed the same dream that, if you become a doctor in Pakistan, you will increase your social stature. It's a very noble profession. And later on, I learned that this was also told to us because it gives you a better opportunity at a good hand in marriage. Because if you're a doctor in Pakistan and if you meet a certain caliber of being pretty or nice looking, you become the most eligible girl everyone wants to marry, and that's why it's called the Dr. Bright phenomena. But what I saw in my medical years was a lot of my peers started getting married, they started having children, and they gave up on that dream right before it started. So they graduated, but they never practiced. And this is what the Dr. Bright phenomena is, that 80% of our medical workforce is women, but unfortunately, even half do not practice and become Dr. Brides and sit at home. I also got married right after my graduation, becoming that Dr. Bride. The only thing different in my journey was I did start my post graduation in radiology. I did an year of it and I got pregnant. and I had to leave my residency because it was a 2 year program and I couldn't finish it while being pregnant. So, in that time, when I was pregnant and at home, I started doing a clinic in a slum, and it was a slum where around 100 to 200 people were living. I used to go there every day. And what I saw was that, me being there in primary healthcare as a doctor really created a difference in the community. And I think a lot of questions that I had in my mind when I was practicing in my medical college in the largest tertiary care hospital of Karachi, where I saw a lot of patients coming with tertiary care issues that could have been managed at a primary healthcare level. And I always thought, why is this happening? Why don't people get the doctors in their community? So when I went into that primary healthcare center, I realized that a doctor in primary care is the answer of all the problems that we see in tertiary care hospitals, or at least most of the problems. That if a patient goes to a doctor in primary care, they will not go to secondary care or tertiary care, and the issues will be managed at the primary care level. So I fell in love with primary care that time. Fast forward 9 months, I had my first daughter, and I had to move to another city with my husband. When I moved to the other city, I fell into postpartum depression because I realized I had become that doctor bride. Because I couldn't practice over there, I couldn't get out of the house, I had to take care of my daughter. And even when I wanted to work, I could not. So, in that time, the nurse who was with me in my clinic in the slum, she started calling me and she said, "Listen, we can't find a doctor to replace you. The clinic is still on, and we need a doctor to see patients." So, in my boredom, in my depression, I said, whenever patients come to you, take me on call. And we started doing on call consultations. And later on, she said, this is not working. They need to see you. So she bought a webcam and she stuck it with tape on her laptop, and we started doing video calls. And in that, just doing that, I realized, okay, I'm in Lahore, I'm 1,000 miles away from Karachi, and I'm doing teleconsultations and seeing patients, and this is working. So why can't we create a network of women doctors across the country that can just provide primary care in communities using telemedicine, and that would just solve a lot of issues of primary healthcare. And I had this aha moment in my life, and I thought, okay, now what should I do next? I had no money to do anything with the idea. So I started writing startup ideas. I pitched it on a few competitions. I got some funding. I participated in a competition in Nepal and just got funding. Got overexcited as a young doctor that someone has given money to my idea. Came back to my original city, Karachi, and started piloting. So when we started Sehat Kahani, the initial model was that we will convert local clinics and communities into telemedicine centers by training the nurse, putting a telemedicine system there, and connecting them to online doctors. So that when patient walked in, a nurse could take initial history and examination, but then connect the patient to the online doctor.
And what year was this when you first started?
This was around 2016, 2006, yeah. And officially, the company started in 2017. So we started making that chain of clinics. The company started growing. From the first day, the clinics were paid. So we started making revenue, and we made the business model in a way that within 12 to 18 months, the clinic would break even on its OPEX, provided someone was giving us the CAPEX. And the company started attracting, it attracted some funding, some soft funding. We started getting popular. I created a team, enrolled myself in accelerators to get the skill of business, etc. But in 2008, my co-founder, who's also a female doctor, we realized that we were really limiting ourselves by being only in low-income areas, because health was just not an issue for the low income in the country. It was an issue of everyone. By that time, apps were also have become famous in Pakistan. So food delivery apps came in, ride hailing apps came in. So we thought that we've already done it for a very difficult market. Why don't we take this model, make it a little more simpler, remove the nurse from the picture, and actually create an app that can provide primary health care to all using the same network of doctors. So we went on creating the application. We raised our seed funding to do that.
How
And the
many
app is
clinics did you have at that time? How many
we
hybrids?
had around 13 clinics at that time. 13.
13, 1 3.
In three
Okay.
provinces. In three provinces, we had 13 clinics. So we started making the application. We didn't do it right the first time, failed, did it again. So by 2019, we had the app. And a very interesting feature that we added in the app, because in the clinic, I had this learning that when patient walked in, and without no waiting time, without no travel, when they were instantly connected to the doctor, that was the aha moment that I saw in the clinics. So I thought, when I will make an app, I will connect the patient to a doctor within 60 seconds. So that there's no wait time and there's no appointment booking. It becomes very easy, like food delivery or ride hailing. So we made that up. We made that and we started talking about the app everywhere. But when the app actually launched, it didn't work. So we had 50, 60 doctors on the app. maybe 10, 15 patients showing up every day, because till that time, also in 2019, in mass cultures, health was very physical in Pakistan. So there was a saying that until you touch a pulse of the patient, healthcare doesn't get delivered. So we launched the app in 2019, December. Wasn't getting a lot of traction. We were almost contemplating, okay, is it going to work? Should we go back to the clinical model? And 6 March 2020, I still remember the date, COVID came in. And on 20th March, the country went to the lockdown. And on 15th March, I got connected to the federal health government, and the person who was heading digital initiative said that we need an app as the country goes in the lockdown. And I've heard you say that you can connect a patient to a doctor within 60 seconds. So we need the app. And within a week, that the app was given by the federal government to everyone, it just exploded. We started getting a lot of consultations on the application. We went from like 10, 12 patients a day to 1,000 patients a day. We went from maybe 50, 60 doctors on the app to 1,000 plus doctors on the application. We set up a call center. We set up quality assurance initiatives. The team just blasted everywhere.
Similar to here in the States, where COVID was a real accelerant in terms of
Yes, it was.
telemedicine adoption.
But we also capitalized on the opportunity. While we gave the app to the government, the app was free. However, we weren't making any money off it, and our clinics shut down because of the lockdown. So financially, we had no money to survive. And we had to keep increasing operations because the government was asking us to give the app everywhere, but they weren't paying us at that time. We had to look for an alternative to make money. So then me and my team sat down and said, listen, how can we make money? And that is when we realized that there's a market in Pakistan who desperately needs services for their employees and families, which is the corporate market. And they were looking for any opportunity to provide a doctor to their employees as they sat at home in lockdown. And we started pitching. So, everyone in my company, there were around 40 people in my company, everyone became a salesperson. And we started pitching to every corporate that we knew, left, right, and center. And over time, 5, 6 corporates signed up. Their CEOs were on boards of other corporates. They pitched us. And from 5, 6 corporates, we went to 50, 60 corporates in 3 months. And from 50, 60 corporates, we have now become the largest corporate telemedicine provider in the country. So we have 1,100 corporates that use Sehat Kahani corporate services. They not only use it for telemedicine, but now we also reimburse their claims digitally. We do their cashless pharmacy through OPD pool management. We do health education sessions for employees. And we work with all 9 health insurance companies in Pakistan. So we have coupled our product with insurance companies, and it is given to.
So really, beyond just providing telemedicine, really much more of a healthcare administration management tool
Yes,
for
yes.
all things administering the insurance and the care.
So, all in all, if I tell you, Sehat Kahani has a clinical model in low income areas where we provide telemedicine, and we also have closet pharmacy. So, we also house pharmacy in our clinics now, and we have 63 of these clinics across Pakistan, the largest telemedicine clinic chain. For our application, we do telemedicine, claim management, pharmacy, and we also do home health care, which is sending a nurse or an attendant to a patient's home, doing 24/7 remote monitoring of the patient and getting them connected to online doctors as need be. We also provide health education services and mental health services on the application. So, all in all, there are around 7 services that we provide through the Sehat Kahani platform today for different kinds of customers, different socioeconomic groups, different genders, as need be.
So you're covering a lot of grounds in home health, in clinic, and corporate market. So what's the total when you add it all up today? How many providers, how many patients are you seeing per year?
So we right now so over the years we've made a network of doctors, and the network of doctors is around 7,600 doctors now. And these are doctors that we have trained over time, or they've taken our trainings. So we have an online learning management system where we train doctors to come back to work or take tutorials or soft courses to be a part of our network, so that as need be, as the recruitment cycle starts, we can just pick doctors from this network and we can start recruiting them. Overall, we have around 1,000 doctors in the system today that come on the app and in the clinics on a daily basis and provide consultations. We did around 900,000 consultations in 2024, and this year we've done 1.2 million consultations. Yeah, we've impacted around 4.3 million consultations. On the application, on the apps totally, we have around 1.6 million users. And on the corporate app, they have families registered as sub-users as well. So on the corporate application, we actually service around 7 million people with 1.3 registered users.
So about 7,500 providers, and it sounds like 1,000 are using this tool consistently on a daily basis. And what's the breakdown between primary care versus specialty care amongst those active providers?
Yeah. So that's very interesting. When we started, around 70% was primary care. So GPs were getting more use more and specialists less. But as we have grown and gotten more and more specialists on board, we actually see like a 60-40 split now. So 60% are still GPs, but 40% are also using specialist services. Particularly, there's some specialities that get used a lot. For example, gynecology, pediatrics, dermatology, cardiology, endocrinology. So bigger issues in Pakistan. And it matches the data that we see in the healthcare burden as well. But more and more people are inclined towards using specialists on the app as well, because it just gives them, a lot of time saving, cost saving, and ease.
So it sounds like there's a couple different channels. You still are working on the clinic model, the
Yes.
hybrid clinic telehealth model, and then you've got your corporate channel. So let's talk about each maybe separately for a second. So corporate channel, is this private insurance, or are these corporate channels also leveraging the public health insurance market?
So, with respect to the clinics, we've changed model a little bit as compared to before. So, initially we used to launch individual clinics, but now Sehat Kahani runs clinics with institutional partners and the government. So, we will partner with an institution who will already has a chain of clinics available, and we will convert those clinics into telemedicine centers. So, there are a number of organizations that we work with. We work with Rotary, we work with 4G Foundation, and then we also take clinics from the government, the dormant PHUs, the basic health units which do not have doctors, and we provide doctors in them. Now, this is where the payer changes. So, in the government setup, the payer is not the patient, the payer is the government. And we've already done 13 basic health units converted to telemedicine centers with one of the regional governments, and we're working on another pilot of 25 with another right now. Now, in terms of the corporate model, our payer is the insurance company. So, the insurance company, the private insurance company, we connect our product with their premium and it is given to the end corporate. There is public health insurance. It's called the Sehat Sahulat card in Pakistan, or the Sehat, and that allows anyone who has a national identity card number to go into a hospital and get hospitalization coverage to a certain percentage. And there are conversations now, including primary healthcare through telemedicine and that, but that has still not happened. So we work primarily with private health insurance companies.
Okay. And on the corporate side, are these corporations large corporations, several thousand employees? Are they small companies? Are they multinationals? What's sort of the composition of the 1,100 corporate partners that you have?
Yeah, so they're comprises of all. So one of our larger clients are banks, because banks generally have larger employee bases. So we have 3 or 4 major banks that have around 16, 17,000 plus employees. Then we have multinationals. So Nestle is our partner, Novo Nordisk is our partner. So these are between maybe 2,000 to 5,000 people. And then there are smaller corporations, technology houses, local companies, family offices. So it's a mix of all sorts of companies. What I've seen is if there's a larger employee base, then the utilization is very effective. So the larger the company, the better the service works for them.
How are these patients using Sehat Kahani? So it sounds like on the clinic side, the 60 plus clinics, the clinic has a certain set of services that are provided on site, and Sehat Kahani is expanding the range of services that can be offered because you can plug into a variety of specialists and increase your supply by leveraging telehealth. So augmenting in-person services with additional supply, different types. Is that correct? And then on the corporate side, how are these patients using your providers? Are they their primary care provider, or is it more just if you have like an urgent care type need, it's late at night and you have a health question, you call Sehat Kahani? What's the use case for these patients in both the clinic model and the corporate model?
So, in the clinical model, we create clinics in communities where there is no physical doctor available for at least 10 to 15 kilometers in the community that we're working with. So we genuinely choose communities which are hard to reach. And at that point, the clinic is used for all primary and early secondary care.
This
So
is
it's
almost back to your roots of when you were providing with just the nurse at the site and no provider on site. Got it.
yes. And
Got
that's
it.
the same model we followed. In fact, over the years, we've gone into more hard to reach areas. So I was still working in a city. But right now, majority of Sehat Kahani clinics, bearing maybe 10 to 15, are all in rural areas, rural villages. Last year, we made a lot of clinics in KPK, which is a northern province, which houses a lot of refugees from Afghanistan, and they have their own set of healthcare issues. So we have intentionally gone into very hard to reach areas where people do not have another alternative, and our clinic would be the only doctor driven clinic there. So patients come to us for all sorts of issues. We have family physicians there for all sorts of primary healthcare issues. Plus, we also have three kinds of specialists in every clinic. So we have gynecologists, pediatricians, and cardiologists. And if need be, we can also attach more specialities if we see certain data coming out of certain clinic. We also introduce mental health services, and we have an organization called British Asian Trust that subsidizes mental health costs in communities because Pakistan only has 500 mental health physicians for 240 million people. So
Mhm.
you can imagine how scarce and how expensive they are. So we also enable mental health services through psychiatrists and psychologists. So our clinics are mainly used for all sorts of primary care
Mhm.
consultations, not just some clinics even work for 12 hours. Another interesting thing that we also did was we started making clinics in the lady health visitor or the nurse's house itself so that she doesn't have to travel anywhere to come to the clinic. She actually has the clinic within her house. So that increases the ownership of the nurse or the lady healthcare visitor that is working with us. And that has proved to be a very successful model in the clinics because it's her own house, it's getting developed, it's getting renovated, she gets motivated, she gets the incentive, she makes more money, so it really helps her become into like a micro entrepreneur. um, on the corporate side, this is not just again used for emergency. It is a primary healthcare app that is supposed to provide primary healthcare services to corporate employees and families who only get hospitalization coverage from their insurance. So, insurance in Pakistan is 95% hospitalization. I get sick enough, I go to the hospital, my insurance covers it. But if I have to go to a doctor in primary care, just show a doctor and get a prescription or get my medicine, that's on me. My company is not paying for me. So when Sehat Kahani comes in, they get this service from the company free of cost. So they come on the application, they do their consultation. If their company has booked pharmacy from us, they do their pharmacy and they have to pay nothing. And we also act as gatekeepers, right? Because we will tell the patient, you don't need to go to a hospital. Your issue is small enough and we'll treat you here and then. So it also is a win-win for the corporate. It's a win-win for the insurance company because the claims go down. And that's why insurance companies love working with us because we actually become kind of gatekeepers for them. So yes, the usage is primary care, early secondary care. The app is 24/7 and it does become the primary mode for corporate employees and families to get primary care coverage, not just emergency.
Is the primary motivation for these employers to sign on to reduce the cost of care because are the employers underwriting the medical insurance expense? Are they self-funded?
Yes, so insurance is taken by the corporate. So the corporate has to pay a premium to the insurance company. And there are two sides of scenarios happen. A lot of times when people go to the hospital to make unnecessary visits, they use their claim ratio. Now, when the entire claim ratio gets used, when you're going to the insurance company the next year to pay a premium, the insurance company will tell you, hey, listen, your claims limit went really overboard, so I'll increase your premium this year. And that's where the corporate loses. How the insurance company has lost is last year they have borne larger claims ratio than paying that premium. So everyone is at loss when higher hospitalization gets used. So that's why when companies like Sehat Kahani come into the picture, if a patient comes to us, we'll tell them, listen, you don't have a problem that needs to go to a tertiary care hospital. We'll see you here. If need be, then you can go. So a lot of those unnecessary tertiary care visits get reduced. The insurance company saves on their claims cost and the corporate saves on their premium next year. And one of our bank partners actually did a study 2 years ago in which they saw that in 2 years that they have used Sehat Kahani service, the claims ratio went down 27%. And this is where 16,000 employees and their families were using Sehat Kahani services. So it did get proven in one of the studies that we did.
So let's talk about the Sehat Kahani financial model. So on the clinic side, you're paid by the government. On the corporate side, you're paid by the corporate health insurance. It sounds like the patients and both cases are not paying Sehat Kahani directly. Is that correct?
So in the clinic, there are two kinds of clinic. Either they are done in partnership with the government or the patient pays itself. So right now, the majority is where the patient paying itself. But as a scale strategy, we are moving more and more towards government or institutional partners paying, because as we reach to more hard to reach areas, the payability becomes a challenge. So while patient paying is good for sustainability, it is also a limiting factor because it inhibits us going to more rural areas where maybe paying 100 rupees might be a challenge for a patient also. And there are lots of localities like these. So it's a scale strategy. On the corporate application, yes, the insurance company or the larger corporate is paying, but we also have a consumer app where the patient is paying themselves. So we also have a third solution where if you are not covered through a corporate or insurance company, if you
Direct to
don't do
patient.
yeah, you come on the application, you pay for the service, and you get that service done. You book your pharmacy, you book your lab, you book your home healthcare. So there's a consumer app available. So there are three models of payment. There's a corporate app, there's a consumer app, and there's a clinic where a patient pays or the government pays on their behalf.
And in these models, is Sehat Kahani always paid on a fee for service basis, or do you have models where you're paid a fixed fee, or maybe you're taking a share of savings? Because you mentioned on the corporate side, a big attraction is reduction in the overall cost. Are you sharing in those savings? So how are you paid at a unit level?
Yeah, so at the clinic, it's a fee for service. Either the patient pays us, or we build the garment or the institutional partner that we're working with. In the corporate, we charge a premium or a retainer at the beginning of the year, depending upon the number of users that are signing up. So it's not per consultation; it's actually per user. And the say that we have is you pay us one time for the number of users, and then you can use unlimited services. So we paid a B2B completely. And on the consumer application, again, it's fee for service. There are different modes of payment. So you can either pay at the time of the consultation or you can buy a subscription, which may be for a month, for 6 months, for a year. So a lot of patients prefer just buying that one time subscription for a year and then they will keep using the consumer app again and again.
So corporate really is capitated. You really have a fixed fee, and the utilization fluctuates accordingly.
Yes, and we have to do we do different scenarios of a high, middle, and low utilization. And that's how our profit gets affected.
Have you explored any type of value-based care arrangements with these corporations where if they realize a reduction in medical utilization, you're receiving some type of bonus or share of that savings?
So we do have a fair utilization policy in every contract. If we see that there is an extreme overusage, and that has happened with one of our, so we partnered up with a microfinance bank. That was a bank that housed a lot of loanees who take loans, microfinance loans, and they wanted to give our app to them because a lot of people, when they take microloans in Pakistan, they would spend in a health catastrophe rather than creating that house or opening that business that they took the loan for. So they gave Sehat Kahani app as a cover so that at least their primary care would be taken at. And they were anticipating a lower usage because what we assume was it's a low income beneficiary. We're giving the app to them directly. Maybe they will not know how to use it. Maybe they will take some time in understanding the concept of the application because mobile phone usage is there in low income areas, but internet and kind of understanding how apps work is still a challenge. But as soon as the app got rolled out, on the second, third day, we started seeing 11, 12 patients waiting for one doctor. So there was an extreme, unrecognized overutilization. And then we went, because we had a fair usage policy, we said that, listen, this has increased. So you need to revise the rates for us. And now we work with them on revised rates. So whenever we see an overconsumption, we do ask for more money to be able to provide that service.
So let's talk about your providers for a second. So how do you recruit these providers? And with so many providers on the platform, how do you maintain consistency of quality? And how do you compensate these providers?
So we do recruit providers from our network, and we do recruitment drives. So we use different social media channels. We use Facebook and Instagram and others. But generally, there are so many doctors in Pakistan that are not working to their full potential. And we don't just recruit doctors from Pakistan. We also recruit doctors from other parts of the world who have a Pakistani PMDC license. So normally a lot of doctors migrate to the country, but when they migrate as a couple, the male member is working and the female member is still home because she has to take care of her family and the children. So the consequences don't change for them, particularly when they go to countries like Middle East or if they go to US. I mean, one of the partners eventually may give up and not practice. So this becomes an opportunity for them to practice as well. So how we recruit them is through social media. Once they come onto the platform, they do have to take the OLP trainings, and they also have to pass some assessments to be active on the platform. And we have different assessments for GPs, and we have different assessments for specialists, and a minimum number of working years that they need to have as well. So if they meet the criteria, if they pass the assessments, then they get recruited on the application. Then we do orientations for them. And then we have a whole medical audit department to review the performance of doctors. And the doctor's performance is reviewed two ways. So one is the audit team takes a sample of the consultations done, and we have some protocols developed on how a consultation needs to be, which ends in a probable diagnosis and a treatment plan and doctor notes. And they review the treatment plan, they review the doctor notes, they review if the diagnosis is according to the symptoms, and they see which doctors are not following the algorithm from that sample, and then they do group or one-on-one sessions to tell them, listen, this is where you're going wrong, and kind of mediate the problem, the issue. So it is done through constant learning and training. The second part is on the application as well as the clinics, we do patient feedback. And 30 to 40% of that feedback, 30 to 40% of patients from the entire month, the feedback is taken from them. And within the feedback, there's also a question asked of how the doctor did. So if there is a certain qualitative feedback for a doctor which is not satisfactory, then that is also taken care by the MLE team. They also conduct group and one-on-one sessions depending upon the severity of the issue, just to make sure that they are complying with the guidelines, they're adhering to the guidelines, etc. And then there are cuts or performance benefits based on their performance as well. So if you're performing really well, we will give you an incentive at the end of the quarter. If you're not performing well and not making certain KPIs, then we will do deductions as well. So it is both approaches. I think your last question was, how do we pay them? Yes. So in the clinics, they are recruited on a salary, because every clinic's OPEX is on a unit structure. So we have one doctor in every clinic, and then we have cover as well. So we pay them a salary for working in the clinic. On the corporate application, we've set prices for GPs and specialists. So we give them fixed prices per consultation because we are charging per user. And on the consumer application, it's a free market. So I am a doctor, I will set my own price on the application, and I will take that fee from the patient. 60 or 70% will come to me, and 30 or 40%, depending upon which category or specialization you are, will come to Sehat Kahani.
Interesting. So they're on the direct to patient. You're really a marketplace intermediary. You're not setting the rates.
Completely a marketplace. Yes.
Understood. What is the percentage of your business that is that third category, direct to patient? Is that a small portion of your business, or?
That's a smaller portion of the business, especially in terms of the revenue. And I'll tell you why. When we raised our pre-series A round, which was in 2021, we did push a lot on the consumer, the B2C application. But then in 2022 onwards, there was a funding crunch globally, which also impacted Pakistan. And if you have to grow a B2C business, particularly which requires a huge behavior change of converting a physical doctor to a virtual doctor at a mass level of 240 million people, you have to spend millions of dollars to make that possible. You have to do a lot of burn in marketing, in exposing yourself at different places, events, out of home marketing. So, as a company, we thought that our strength at that time was our clinics as well as our corporate business, which is not a very heavy burn business. So, we thought that instead of burning millions of dollars there, we reinvest in our corporate business as well as in our clinics and push them forward. So, right now, around 60 to 70% of our business is B2B. Around 15% is the clinics from a revenue point of view, and around 15% is the application.
Very nice. Are you able to track outcomes? Number of preventative immunizations delivered or other types of preventative services that you're able to report back to the government or to your corporate partners?
So we work with 2 regional governments, and so we don't have to report anything back because there's a live dashboard that is available to all our partners. So the government has access to a dashboard, and the corporates have access to the dashboard as well.
Is that dashboard through provided by Sehat Kahani, or?
And it's complete based on Power BI. So whatever is happening, for example, today, if 100 consultations have happened, it will tell you 100 consultations happen. Male patients this much, female patient this much. These are the top 5 diseases. These are the geographical splits. These are the age splits. So they can see in real time what is happening. And if there is an epidemic, so for example, if we see some very out of the normal activities, then the MLE team reports back. So for example, with one of our corporate partners, we saw unprecedented cases of diarrhea coming out from one geographical location. And we reported it back to them. And when they actually investigated it, the water line that was coming in the entire facility was faulty. It was contaminated, and they had to change the waterlining of the community. Particularly in COVID, when we were doing consultations, we were reporting back a lot of COVID patients who needed hospitalization, who needed isolation at home, who needed quarantine, and the government was able to do heat maps because using our data as well as other providers' data. And right now, even our communities, we gather data and we work with the local government to do preventative healthcare strategies. So that data on an anonymized basis is available. Yes, internally, we do track a lot of KPIs. So, for example, in the clinics, we see how many women are coming, how many children are coming, what is the age split, how many patients are coming for first consultation, for second, for third consultation, how many patients are we actually limiting from going to a tertiary care hospital, which means that how many lives are we improving by resolving their issues at the primary care level. Then disease wise, how many patients are getting primary healthcare services in MNCH, how many patients are getting family planning services, how many patients are getting antenatal and postnatal, diabetes cases, cardiac cases. So that's like, an entire cohort of data that we gather around our clinics as well as on the application.
So you're providing care, you're providing claims administration for the corporates, you're providing real-time analytics on care delivery. Are you also an EMR, electronic medical record system?
Yes. So we do have an EMR, and in the clinics, it is the responsibility of the nurse to fill the EMR on behalf of the patient. So there we have a very specialized EMR, which is filled by the nurse. And if the doctor comes on the call and sees the EMR not filled, then it is the responsibility of the doctor to fill the EMR,
Is
because
that a
many nurses.
homegrown system, or is that a third party system that
No,
you?
we've developed it ourselves. And we've used the Pakistani guidelines of history taking and examination to be able to do that. So the entire EMR is filled in the clinics. On the mobile application, the EMR is present within the application. It is responsibility of the patient to fill it out. So there's an entire section where they can fill the EMR. However, because the patient comes online and they quickly want to connect to a doctor, majority of the patients do not fill that EMR the first time they come on the app, and then the app keeps sending them prompts that fill this section. If you've done your family history, then fill your sexual history or fill your past consultation history. So there, the EMR for us mainly is the history provided by the patient, the symptoms, the doctor notes that is done by the doctor during the consultation, the diagnosis, and the treatment plan. So that's what we follow mainly on the app.
So we could talk for hours. This is fascinating, but we've only got time for two more questions. So one is forward looking for Sehat Kahani. When you think about the next 3 to 5 years, where will the company be? What will be different from today? Will you be in advancing the EMR concept? Will you be expanding to new markets? What's your goal if you look out into the foreseeable future?
So in 2023, when the funding crunch grew, and right as we're sitting in 2025, there's a couple of realizations that have happened. One of those realizations is while we're scaling in Pakistan, our patient profitability is not increasing to the level as we want to, because inflation has increased, purchase powers have gone down, funding market is a bit slow. So generally, scale is slow in Pakistan. And if we have to increase our per patient profitability, we have to venture into a few high growth markets to be able to sustain and grow as a company. So we started working in the GCC market last year, and we already are active in UAE. And the next market that we're looking is Saudi Arabia. Again, because there are a lot of cultural similarities, similar healthcare burdens, a lot of expats, Pakistani expat doctors available. Although, we will hire local doctors well, but if we had a big community of doctors already in our network to start with. And when we saw per patient profitability, it was growing 4x as compared to Pakistan. So our regional expansion plan is for the GCC market for the first 2 years for the corporate application. So this is where we'll take our corporate application. But we also have plans of launching our clinical model in other geographies, which might have doctor-patient mismatch or primary healthcare issues. And this year we are opening 2 clinics in Kenya with a fund that we have recently done. And we are piloting in Kenya that how can we help primary care in Kenya do telemedicine clinics, and how can we connect ourselves to health insurance there, primarily the public health insurance. So we're growing in 2 different regions with 2 different products. And I think the next 2 years will be a lot of trial and error to see which product work in which section. But, for me, sky's the limit. I want to be at least in 5 geographies in the next 5 years from a scale perspective. But at the same time, we're not just scaling geographically, we also want to scale in depth. So as we are moving in different geographies, we're also really making sure our technology has the ability to kind of manage such a big patient load. So this year we're working a lot on our AI solutions of, how can we create doctor assistants? How can we make our Emily more automated? How can we do our e-prescriptions more automated? How can we, create more AI-based inventory management system for rapid pharmacy delivery? So a lot of work that we're doing with technology also to make sure that we have a good service to provide, not just in Pakistan, but regionally as well.
We started with a question about the overall Pakistani healthcare system, the priorities and the needs within the country, and I want to end on another Pakistani healthcare system question. What is the thing that you're most proud of with regard to the Pakistani healthcare system and care delivery ecosystem? And what's something that if you were to export it to another country, maybe it's the telehealth concept, maybe the dynamics have been conducive to adopting telehealth. But what's something that you think another country could learn from the Pakistani care delivery system to benefit?
I think one thing that I'm extremely proud of is the resilience that I've seen at any level of care delivery by the providers. So, whether I meet a healthcare worker who's working in a community, or a nurse who wants to work with us, or a doctor who wants to work with us, or a nurse that is providing home healthcare services, or a rider that's providing pharmacy, I think the idea of providing care is embedded in our culture. So, as a culture, we are very hospitable people. We want to give the best. So, for example, if you come to my house right now, I will make sure that you get the best of food, the best of room for you to stay in. So, that value of providing care, I have seen in the community that I've worked as well. A lot of times, I felt that we
You
are
might
not.
get a lot of visitors from the podcast audience based on
We
that comment.
always welcome them. I mean, if you just Google travel vloggers visits to Pakistan, you will see that when travel vloggers come to Pakistan, no one takes money from them when they travel, because we are always taught that like welcoming a guest is like God. So I think the power of healing and the power of giving and the resilience with which, with limited supplies, limited resources, I've seen that women doctors want to give or the nurses want to give. If I had one thing to export, I will export this power of giving, this power of healing, this power of resilience. Because I think if Sehat Kahani has expanded to this level, it is because we had a very resilient workforce standing behind us who worked in very difficult circumstances even till today to provide the quality of care that they are providing at
Yeah,
all
I think
levels.
I think it's interesting that what you just mentioned, the two things combined, scarcity of resources combined with a innate sense and desire to provide high quality service,
Yeah.
hospitable service and care. And so that those two things together yield creative solutions, innovation. And that's exactly what you have done at Sehat Kahani. So it makes perfect sense and is a good way to wrap up the conversation. Dr. Sarah, I really want to thank you. This has been a fascinating conversation and an incredible story of what you've built to date, and we wish you lots of luck in your continued development. And thank you for taking the time to share the story of Sehat Kahani today. I really appreciate it.
Thank you, and I hope it gives people some good perspective of what we're doing in Pakistan. And thank you for having me on the show. Thank you.
Thank you. Take care.